Ma'am, we are live. Dr.
Okay,
Priyanka,
now we can continue. Yeah.
Good afternoon, everyone. I will be presenting a study group on the topic of analysis of ophthalmic cell manifestations of invasive rhinoorbital cerebral mucormycosis in COVID-19 patients. Since we know that mucormycosis belongs to the order Mucorales of the class Zygomycetes, which are ubiquitous in nature, and this fungus develop rapidly and release large number of spores. The human might be infected through inhalation of these spores and cause mucormycosis, which is a rare, acute, invasive, and life-threatening fungal infection that mainly affects the immunocompromised patients. The susceptible patients are infected by direct invasion with marked tissue necrosis of adjacent structures, forming characteristic black ashar, followed by rapid progression and angio invasion from the nasal and sinus mucosa into the orbit and brain. The risk of ROCM co-infection in patients with acute respiratory distress, receiving broad-spectrum antibiotics for a long time, steroids, and supported by invasive or non-invasive ventilation are at higher risk. The prevalence of co-infection was 63.64% among COVID-19 fatalities in a current study. The study design I have chosen is prospective interventional. SIMS Bilaspur was my study center. I have taken inpatients of ROCM ward, SIMS Bilaspur, and the study was from May 2021 to July 2021. It included microbiologically confirmed ROCM co-infected patients in severe COVID-19 patients. The study technique was mainly detailed history taking, clinical and ophthalmological examination, along with the surgical intervention required. The bias I found was lost to follow-up, and the total sample size of my study is 26. I have recruited all the patients from ROCM ward who were microbiologically confirmed COVID-19 patients. I took detailed history about their COVID-19 status, history of contact with any COVID-19 positive patients, history of hospitalization or medications like steroids, use of oxygenation during their hospital stay, duration of hospital stay, history of any prevailing chronic illnesses or surgical history. A comprehensive ophthalmological evaluation, otorhinological examination, and neurological examinations were done. Patients were examined in terms of uncorrected and best visual acuity on Stellen's distant vision chart. Examination was done with diffuse light, with complete anterior segment examination on slit lamp, and complete posterior segment examination with the help of indirect ophthalmoscope, and if patient's general condition was good, with 90-day biomicroscopy in slit lamp. Each patient was investigated for routine blood investigations like complete blood count, liver function test, kidney function test, blood sugar, viral marker, serum electrolytes, ESR, CRP, tuberculin test, and had undergone CT or MRI scan as per required with contrast. The diabetic patients were controlled with insulin therapy. Systemic amphotericin B was given at a dose of 1 milligram per kg per day, increasing to a total of 3 gram per day. The maximum duration of therapy given was 6 weeks, and close monitoring of the blood investigations was done. Retrobulbar liposomal amphotericin B was instituted in 7 patients. The dose was 1 ml of 3.5 milligram per ml. 3 consecutive doses were given of same dose each time. Surgical debridement of all the 26 patients were done with FES surgery and sinus wash with liposomal amphotericin B. Although repeat surgery was done in 4 patients due to recurrence. This is the photo of first patient with black ashar over the eyelids and black ashar formation over the hard palate. The patient was found to have CNS involvement, and the patient died on the very first day of admission. This is the photo of second patient who required exenteration due to involvement of unilateral orbit and also dissemination into the frontal lobe of the brain. But the patient has survived. This is the picture of third patient who required removal of the orbital wall, inferior orbital wall, and had undergone FES surgery with uncinectomy and sphenoidectomy. The study included 9 female and 11 male with a mean age of 57.5 years. All 26 patients I had taken were uncontrolled diabetic with a mean diagnosis of the disease duration of approximately 3.67 years. All patients had COVID-19 associated acute respiratory distress and were put under oxygen support and received corticosteroids in the past. 3 patients had chronic renal failure and 1 developed acute renal failure during the course of amphotericin B. 3 patients' coagulation status showed an increase in D dimer and received low molecular weight heparin at a dose of 1 milligram per kg body weight. The mean time interval between COVID-19 diagnosis and ROM diagnosis was approximately 3.46 days. All our patients developed these symptoms while being treated in the hospital, and all underwent within an average of 5.1 days. I took 26 cases with a mean age of 57.5 with 9 females and 17 males. All 26 patients were uncontrolled diabetic with 16 known cases of hypertension. 3 were having thyroid disease. 2 of them were having heart disease. 4 developed facial palsy and 3 were having chronic kidney disease. Sino-orbital involvement was present in all 26 patients, whereas cerebral involvement was seen in only 3 patients. The orbital apex syndrome was found in 4 patients, with 6 patients showing features of orbital cellulitis. On CT scan, the most common finding was thickening of sinus mucosa, intraorbital involvement, and inflammation in periorbital muscle and fat. The cavernous sinus was involved in only 1 patient who died on the very first day of admission. On nasal endoscopy, black HR was present in approximately 16 patients. All 26 patients were laboratory confirmed COVID-19 positive with use of oxygen during their hospitalization and steroid treatment taken during hospital stay and after they were discharged. Surgical debridement was done in all 26 patients with injection amphotericin B injectable, and only 7 patients received retrobulbar amphotericin. 17 patients survived, whereas 2 patients had recurrence on follow-up and 3 died. The patients presented with breathing difficulty, fever, headache, eye pain, diminution of vision, cranial nerve palsy, blepharotosis, facial swelling and pain, periorbital edema, ocular purulent discharge, proptosis. Mostly these ocular symptoms were usually unilateral. And on fundus examination, 2 patients showed central retinal artery occlusion, 3 patients were having optic atrophy, unilateral, 1 was having macular atrophy, and 5 patients had myopic fundus, with 4 showing choroiditic patches. From the findings, we can say that the left eye was involved in 9 patients, while the right eye was involved in 17 patients. The common presenting symptoms and signs were orbital pain, facial palsy, proptosis, conjunctival hyperemia or chemosis, ptosis, and diminution of vision. MRI findings showed involvement of lateral rectus muscle, most commonly, followed by inferior rectus muscle, then medial rectus, and the involvement of extracorneal fat was involved in approximately 13 patients. Out of all 26 ROCM patients, the ethmoid sinus was involved in 90% of them, with maxillary sinus approximately 82.4%, followed by sphenoid and frontal sinuses. In 32 patients, of all the 72 patients admitted in the ROCM ward, were having multiple sinus involvement. Intracranial involvement was seen only in 3 patients who expired on the day of admission. The 21 patients who underwent surgical debridement were having good survival and are regular on follow-up. 7 patients had been given retrobulbar liposomal amphotericin B injections and are having good ophthalmic outcome. Corticosteroids not only reduce the activity of immune system, but also cause drug-induced hyperglycemia. Maculares have a ketone reductase enzyme. So they thrive in hyperglycemia and diabetic ketoacidosis states. So the link between the diabetic and mucormycosis was thus explained. As per our patient's clinical data, 100% had uncontrolled diabetic or diabetic ketoacidosis. So the COVID-19 infection was more prevalent in such patients. Ocular involvement develops following direct invasion from the adjacent orbital structures. Solely orbital involvement was never seen in any of our patients. However, one of our patients developed acute renal disease as side effect of systemic amphotericin B, and throughout her treatment, the amphotericin B was intermittently held to improve the renal function and supplemented with antifungal tablet posaconazole in the dose of 200 milligram thrice on the first day, then 200 milligram once for the next 7 days. Retrobulbar amphotericin B injection may cause a post-injection pro-inflammatory state and conjunctival chemosis with development of an orbital compartment syndrome. None of our patients experienced this form of reaction within 3 months of their follow-up, although close monitoring of the patient's orbital examination, including orbital examinations like visual acuity, conjunctival chemosis, and IOP testing are still done. I conclude by saying that antifungal treatment alone is ineffective due to vascular thrombosis and an extensive ischemic necrosis barrier. So, to make antifungal treatment effective, radical debridement of infected and necrotic tissue is must with drainage of infected paranasal sinuses. The coexistence of ROM and severe COVID-19 infection is associated with higher mortality rates than previously reported in non-COVID-19 patients. The study's limitation is that our results may not reflect the exact survival rate of ROM in COVID-19 patients since it has a very small sample size. These are my references. Thank you.
Okay, thank you, Dr. Priyanka, for the nice presentation.
Yes, ma'am.
I have a question for you. What
Yes,
was the visual prognosis in your patients?
In 7 patients who received retrobulbar liposomal amphotericin B, recovered from approximately 360 vision to 660 vision.
Okay. So now you tell me, you said that only antifungal drugs are not going to help the patient in improving the rhino-orbital mucormycosis. So you
Yes,
had to do the radical surgical debridement. So what was done in your cases? What surgery was done so that the vision could be restored?
Ma'am, in our cases, focal endoscopic sinus surgery was done in almost every patient. 21 patients out of 26 underwent focal endoscopic sinus surgery. The remaining 5 patients were not taken for the surgery because their general condition was poor.
Okay, so only the sinus surgery was done. The orbit and the eyeball were you people tried to save that as far as possible.
Yes, ma'am. 2 patients.
So it was not extending into the orbital cavity?
No, ma'am. Only 2 patients. In only 2 patients, we removed the orbital inferior wall due to extensive involvement. And in patients with extracorneal fat inflammation, the systemic antifungal was effective after the 6 weeks follow-up.
So how do you decide whether or systemic antifungal is to be given or the retrobulbar antifungals are to be given?
Ma'am, we followed the patient for the first 5 days of their admission. If the patient visual acuity was...
You'll wait for first 5 days. This has improved drastically. This has progressed drastically, as far as I know.
No, ma'am.
So will you wait for 5 days?
Ma'am, due to other investigations and waiting for the MRI and CT scan reports in our setting, it took 5 days for a patient to take to the operation theater. So within these 5 days, if the visual acuity of the patient declined, we gave those patients retrobulbar liposomal amphotericin B.
Okay. Were any of your patients having systemic mucormycosis apart from orbital involvement and the sinus involvement? Any
Yes, ma'am.
systemic organ was
One
involved?
patient, ma'am, the patient I have showed in the first picture, who came to us with black ashar over the eyelid, hard palate, and was associated with COVID-19, had a history of COVID-19 positive 3 months back, but presented to us with black ashar acutely within 3 days. He was having systemic...
Dr. Prita. Thank you so much. Thank you.
Thank you.
Who is the next speaker? Anushka?
Good evening, ma'am. Yes, ma'am. Shall I start?
Yeah, you can.
Ma'am, here my screen is not sharing. It is telling only the host can share the screen. May I request the host to please allow me to share my screen? Hello? Is my voice hello?
Anushka, I can hear your voice. You can continue. Mr. Rohit?
Yes, ma'am. But my I'm unable to share my screen, ma'am. It is saying only the host can share the screen.
Mr. Rohit?
ঠিক আছে बढ़िया এই पूछा পাঠাবেন আচ্ছা এই টেলিফোনটা আমার তো দেখবেন তো টেলিফোনে কেন খুলছে না একটা জুমে দেখুন তো এইখানে একটা হল খুলতে পারলে ভালো
Namaskar, sir.
हेलो नमस्कार 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 so
Pragati. Yeah, how are you, sir?
fine this is hall 4 eh this is hall
No, I
4
can't hear you, sir.
and who is our judge here? Any judge present here?
Yeah, Pragati.
Dr. Kritika
Pragati
Pal Chaudhary,
here
no.
judging the session.
Who?
Dr.
Doc-
Pragati Garg, sir.
Dr. Pragati Garg. Okay. Thank you very
Garg.
much, madam. Carry on, Professor Pragati Garg. Carry on. This is hall 4, eh?
Sir, my student cannot share her screen. I am requesting the host of the meeting to allow her to share the screen.
You carry on. How many participants? See मैं कनेक्ट करूँ. आप कौन सा हल करते हैं? आप हॉल 2. आप ये 3 भैया नहीं 3 कर दो. तो इधर में प्रगति कर hello, who are the students present here in hall 6? This is hall 6. Akshita Singh is present. No.
Sir, this is hall 4, sir.
This is hall 4, yes. Hall 4, who are present here? Dr. Anushka Srivastava is present here, eh?
Yes, sir.
Yes, and Niveda Singh present here?
Yes, sir, present.
Yes. Then hall 4, Bhanu is present here. Bhanu from Salem is present here. Bhanu M? No. Then Keshav Sood is present here from Ghaziabad. Keshav Sood. Dr. Rihik De is present here. Mr. Rihik De from Kolkata.
Sir, there are only 3 students, sir. Only 3 students, Dr. Priyanka, Dr. Niveda, and Dr. Anushka.
Dr. Priyanka, Dr. Anushka. Dr. Priyanka from which medical college?
Sims Bilaspur, Chhattisgarh, sir.
Sims Bilaspur.
Yes, sir.
Yes. So, Professor Garg, you are here, huh? Professor Pragati Garg is here.
Sir, I am the judge over
Professor
here.
Pragati Garg is here. As judge, Professor Garg is here. Who
Sir,
is the
only
judge?
one judge.
Huh?
Dr. Pragati Garg is the judge over.
Excuse me, your photo is not there. I cannot hear your name properly. Can you tell your name?
Sir, I
Name?
can hear you. I'm Dr. Pragati.
Doctor? सुनो, उनका नाम क्या है?
Pragati Garg.
Pragati Garg. Yes. Thank you, madam. Carry on. Carry on. Carry on. Okay. Okay. Thank you. Carry on. Carry on. I am in this hall. Okay. Carry on. अरे একটা শুনলে আপনার হবে না আপনার কিছু দেখে যেতে পারছে আপনার তো প্রত্যেকটাই ভালো লাগবে প্রত্যেকটা আপনাকে শুনে শুনে তুমি কোন হল तुम कौन सा हॉल আপনার প্রত্যেকটা ছেলে মেয়ে প্লিজ স্টার্ট প্লিজ স্টার্ট
Sir, I am unable to share my screen. Sir, can you please request the host to allow me to share my screen?
Hello. There or Mr. Rohit there? Hello. Anushka, you start without the screen sharing. Anushka? Anushka, can you hear me? Anushka, you can start your presentation.
Oh, yes, ma'am. Is the screen visible, ma'am?
Yes.
Yes, ma'am. Good evening, everyone. Today, I, Anushka Srivastava from Government Medical College, Raigarh, Chhattisgarh, feel obliged to get this opportunity of presenting my topic in front of you all. So, I have chosen this topic of cortical cataract as we get so many cases of cortical cataract every day in our OPD because this is one of the commonest concern in our region, Chhattisgarh. So, let me give you an idea about the cortical cataract. So first, I'm starting with the what is Sinai cataract or the age-related cataract. As we know that this is one of the commonest type of acquired cataract, which affects equally the persons of either sex, usually above the age of 50 years. And this condition is usually bilateral, but almost always one eye is affected earlier than the other. So the Sinai cataract refers to the loss of vision in the dim light. There are two types of senile cataract, the cortical one and the nuclear one. The cortical is also known as the soft cataract and the nuclear is known as the hard cataract. There are some stages which progresses from the immature, mature to hypermature stages of the senile cataract. This is the course of events which shows how the development of the opacification happens in the cortical lens fiber. So, as I have told that this is most commonly in the age group of 40 to 50 years of age. So, with increasing age, what happens is there is decrease in the function of the active transport pump mechanism of the lens, which leads to reversal of the sodium and potassium ratio. So, the sodium rises and the potassium decreases. So, the rise in sodium level leads to hydration of the lens fiber, which causes denaturation of the lens proteins and hence the opacification of cortical lens fibers. In the same way, there is a reduction in the oxidative reactions, which leads to decreased level of amino acids, and which hence leads to decreased synthesis of proteins in the lens fiber and denaturation of the lens protein. It also leads to opacification of the cortical lens fibers. So there are 5 stages of maturation of the Sinai cataract. We have stage of lamellar separation, then it progresses to stage of incipient cataract, then to immature, then mature, and then finally to hypermature Sinai cataract. First stage is stage of lamellar separation. Due to hydration of the lens fiber, the cortical fibers, they get separated because of the filling of the fluid in between the fibers, and this condition can be demonstrated only by the slit lamp examination. Here we find the gray appearance of the pupil, and in this stage the changes are reversible. Then this lamellar separation progresses to incipient cataract. In incipient cataract, we see wedge-shaped opacities with clear areas in between, also known as the lens stria. These opacities are most common in the periphery and the lower nasal quadrant, and this we can see only in a dilated pupil. Irregularities in diffraction, visual deterioration, and polyopia is also seen. This stage is also known as the cuneiform cataract stage. Then the incipient cataract progresses to immature Sinai cataract. Here, the opacification becomes more diffuse and irregular, and the lens becomes more swollen due to progressive hydration, and it is also known as intumescent cataract. Here, the iris shadow is still visible, and the interior chamber here becomes shallow. As the fluid accumulates, it causes swelling of the lens, and immature cataract now progresses to intumescent cataract, which is also known as the mature Sinai cataract. Here, complete opacification occurs, and here the name is mature, so whole of the cortex is involved here, and the lens appear pearly white in color, which is also known as a ripe cataract. The mature cataract then further progresses to the hypermature cataract, and this hypermature cataract is divided into 2 forms. One is Morganian cataract and one is the sclerotic cataract. In the Morganian cataract, there is liquefaction of the cortex. The whole cortex liquefies, and due to this liquefaction, there is sinking of the nucleus, and hence we can see the most common complication of hypermature cataract here, which is the subluxation of the lens. Then the second form is the sclerotic hypermature cataract. In this cataract, the interior capsule, it becomes wrinkled or leathery, and the most common complication is here also is the subluxation of lens. The most common complication of the Morganian cataract is also the phacolytic glaucoma, which is a lens-induced glaucoma. The clinical features which we see in the Sinai cataract are grayer, uniocular polyopia, colored halos, black spot in front of eyes, image blur, distortion of images and misty vision, and deterioration of vision. So the treatment of the Sinai cataract, if we talk about the cortical cataract, then cortical cataract we prescribe preferably in the stage of the immature cataract. First, we try to correct the vision by prescribing the convex glasses, and then if the we don't see any changes, then we switch to perform small incision cataract surgery with IOL implantation. But in mature cataract, in the stage of mature cataract, we cannot correct it by prescribing the glasses. So we directly plan for the small incision cataract surgery with IOL implantation. Thank you, ma'am.
Thank you, Dr. Anushka. There is one question for you. You have
Yes, ma'am.
always planned for small incision cataract surgery. Why didn't you go for the phacoemulsification? And why were you waiting for the cataract to get matured?
Actually, in our setting, that the machine is quite expensive. So
Fine,
and
fine.
the
It's okay. The machine is expensive. That doesn't mean we are not talking about what you people are doing at your center, but actually what is the ideal thing, what everybody
Ma'am,
should do.
now the complications also and the incision also in phacoemulsification is low, so the healing process is quite quicker in case of phacoemulsification, and also the risk complications of astigmatism is low because of the small incision. So if that facility is available, we should prefer phacoemulsification.
Okay. How do you calculate the intraocular lens power, and what should be the ideal situation in which you should land the patient to, whether emmetropic, myopic, or hypermetropic?
Ma'am, there is a formula known as SRK formula, which is for calculating the IOL power. That is P is equal to A minus 2.5 L minus 0.9 K. So where we measure the corneal curvature by biometry and the axis of the eyeball. And by using this formula, we calculate the IOL to be implanted in the patient.
Okay, fine. Okay, how do you differentiate whether the patient is of senile cataract or a diabetic cataract?
Ma'am, in
What
diabetic
is
cataract,
the,
yes, ma'am. In diabetic cataract, there is a sign of snowflake sign which is visible in the lens. So either by investigation we can confirm it that it is a diabetic cataract, and also by clinical examination we can say it is a diabetic cataract.
okay, the last question. What are the various tests to know the macular function? Before surgery, you should know whether the macula is functioning normally or not. The various tests for that. Cortical cataract, nuclear cataract, or whatever, the senile cataract is so common. Before surgery, it is going to ask about the visual acuity after surgery. So you should know whether you'll be able to get the actual result or not. That is going to check macula. Can you name only few of them?
Ma'am, we can perform Maddox rod test,
Okay,
or also we can do two-right discrimination test.
2 point. Okay.
Ma'am, we can also see for color perception. It will indicate whether the optic nerve is normal or not.
चलो ठीक है. Okay, thank you, Anushka.
Yes, ma'am. Thank you, ma'am.
Now the third candidate, Niveda Sahara.
Yes, ma'am. I'll present now, ma'am.
Hmm.
I'll share my screen. Ma'am, I'm unable to share the screen.
Okay. Ask the organizers, request them.
I request the organizer permission for me to share the screen. Host. Ma'am, I have a video to show. So I need permission to share the screen, ma'am.
Hello.
Yes,
Can
ma'am.
the organizers of the meeting can hear me? Hello. Kindly help Niveda to share the screen. They're not responding back.
You can show the video, but you should have to tell something by yourself.
No, sir, I need to share the screen.
Okay.
I need permission to do that.
Okay.
The host has disabled it.
Anchor person, please help.
Ma'am, everybody has been able to present. What is the problem you are facing?
Sir, I'm unable to share my screen.
You are on a Windows or you are on a Mac?
I'm on Windows, sir. I'm on Windows.
So just click on the blue button. I mean the green button on the bottom. It says share.
Yes, sir. Yes, sir. But it says the host disable participant screen sharing.
Absolutely not, ma'am. Just a sec. Just a sec, ma'am.
हमारे चारों बच्चा प्रेजेंट किया, बहुत बढ़िया प्रेजेंट किया, देखता हूँ।
Is it related to toilet?
Something is coming regarding I-band.
Yes, ma'am, it is related to that.
Ma'am, shall I leave the meeting and join it from my phone and show the screen through my phone?
Can you just wait for a minute, doctor?
Yes.
This is the job. It's not complete.
ये बोला है कौन सा रूम में अच्छा होता है, रूम में देखो एसी चलेगा,
आवाज थोड़ा आता है जिसमें वहां पे ऑडियो
हमारे वो इंटर्न लोग को लैपटॉप है ना, बोलो तो और 2 लैपटॉप लाने के, वो हमारे 6 प्लेटफॉर्म तैयार हो जाए, बोला और 3 इंटर्न और 3 लैपटॉप लेकर के, 3 इंटर्न को बोलो 3 लैपटॉप लेकर के चल जाए।
Doctor, can you try now?
Yes, sir. Yes, sir. It still says it's disabled.
Can you just log on and log off?
Yes, sir.
3 लैपटॉप लेकर के आप 3 लैपटॉप का जरूरत है, तो 6 प्लेटफॉर्म हो गए, 3 लैपटॉप सब लेके आओ।
session
সব এই অনেকই আছে, আপনার কিন্তু ইউজি শেষ হয়ে গেল, এরপরে তো পিজি হবে, ইউজি শেষ,
এগুলো হচ্ছে
সব কিছু এটা সব বাউন্ড লেখা আছে, আছে।
কালেকশন হয়েছে এটা শেষ হোক,
ইউজিটা শেষ হয়ে যাবে,
আপনি বলে দিন বি দেয়ার ফর দা ফাইনাল সেশন। আগে কাকে বলবো?
রুমাকে বলুন, রুমার ওখানে কোনো ক্যান্ডিডেট নেই, প্রজ্ঞাপন্নাকে বলুন, ওর ওখানে কোনো ক্যান্ডিডেট নেই,
মানে এইটা ফাইনাল সেশন।
সেখানে যার ক্যান্ডিডেট নেই তাদেরকে বলুন, রুমাকে বলুন, প্রজ্ঞাপন্না
আর একজন
সুচিত্রা
Sir, still I am unable to share the video, sir.
What happened?
Sir,
What
I
happened?
am
Huh?
unable to share the screen.
Sir,
I'll join. Sir, then I'll join through my phone, and like the other participants did, I'll show the video through my phone.
Sure, sure. You can do whatever way you can find it best.
Okay, sir. Thank you, sir.
Ruma. Hello, Ruma.
Can I?
Hello. Five candidates were there. They were present at the beginning only.
Dr. Samant, you are required in hall 2, sir.
Hall 2. May I have to go to hall 2? Why? Hall 2? Yeah.
Dr.
Ruma Das is there.
Yes,
in hall
she's
2.
asking for you. She's asking for you, sir.
Yeah, Dr. Chakraborty is talking with Dr. Ruma Das in hall 2. Okay, no problem. Hall 2. Okay. What about this hall? Why no presentation going on right now? Hello? Why no presentation going on?
I'm just allowing them just a sec. Who wants to present?
Hello?
Who wants to present?
Hello?
The two candidates left, Anushka
Hello,
and Raj Neel. Anushka and Raj Neel. Whosoever is there, kindly start with the presentation.
Just a second.
Sir? I cannot understand.
Yes, ma'am. Tell me how can you help?
अरे काम चल रहा है, हमारे मीटिंग चल रहा था, कहाँ से ये करते हो? छोड़ दो. Yes.
Sir.
Yes. Carry on.
Yes, sir.
Let them to talk. Let them to talk. They are all the UG students. They should be allowed time. We are not at all in a hurry. Let them to talk and finish their presentation. We are not at all in a hurry.
Who wants to present?
Yes.
Who wants to present?
One, Dr. Niveda is trying to present, but couldn't. You please tell. Dr. Sara, what happened to you?
Yeah, Dr. Nivedita, please try now.
Signed out. What happened to her? She couldn't.
Sir. Sir. Sir.
Hello.
Yes, sir.
Dr. Nivedita, can you try sharing, please?
Yes, sir. Sir, shall I start presenting?
Please, can you share?
Yes, sir. Now I can share, sir. Good afternoon. Good evening, respected judges on the dais and my fellow presenters. I'm Niveda Sara Tensing. I'm from 2018 MBBS batch from Amrita Institute of Medical Science and Research, Kochi, Kerala. So today I'll be presenting on our very own virtual reality based anatomical model of the eye, which we have developed at our very own institute. So technological advancements have always been a boon for 21st century education, and the recent expansion in development and availability of softwares such as virtual reality, augmented reality, and 3D printing have actually led to the use of these technologies in modern education. As we all know, and we all experience, traditional methods of teaching subjects adopted by medical colleges like diagrams, flashcards, videos often do not provide students with complete understanding of certain areas or certain subjects like anatomy of the eye, for example. The eye, as it is a very small and very delicate structure, in fact, human eye, so hence gross dissection does not always provide students with thorough understanding of its intricate structures. And another thing is many colleges do use bullseye to dissect for dissection of eye. So that is why VR, which is or virtual reality, which allows a multi-sensory interaction with a virtual environment, which is basically a three-dimensional space that is created by using AI and graphics, or commonly called VFX. Thereby, it allows us to have an interaction, proper interaction with the environment. Hence, it is an ideally suited tool for effective learning and understanding of small, tiny, intricate anatomy. And it also helps, thereby it also helps students to have a clear mental picture and thorough understanding of these structures. Hence, virtual reality based learning is a very promising way of imparting quality education. So in this presentation, as I mentioned before, we'll be showing our indigenously developed virtual reality model of the eye. Moving on to our model making. So basically, we started off by making a 3D model, which is done by a software called CAD and CAD Autodesk Inventor, where we made individual parts of the eye and then we assembled it all together into a single file. And then the next process was rendering. Rendering is basically done to give a realistic appearance to the eye, and that was done using the software called Blender. And then finally, for making virtual reality, we use the virtual reality video gaming software called Unity to develop the virtual reality video. Now, as you can see, these three pictures are the pictures of our model in the second stage. That is after we completed rendering in Blender software. Now, moving on to the anatomy. And the VR model. So I'll be showing you a short video. Ma'am, can you see the screen?
Yes, it's visible. Yeah, it's visible.
As you can see, this is a video. And on one side, you have the screen recorded video of our virtual reality model. And the other side, you can see me viewing the eye. So here you can see the extraocular muscles and the blood supply, venous supply and arterial supply. And then these you can see all the extraocular muscles, its insertion. You can see the cornea, the lens. And now you can see me walk through into the lens. Now you can see me entering the eye. You can see the cornea, the anterior chamber, and we have even added trabecular meshwork, and these are the ciliary body, the lens. You can see the ora serrata, the retina. You can also see the optic disc and the retinal blood supply. Ma'am, you can see the iris. Here you have the lens. Ma'am, you can actually see small layers of even the cornea, and this is the trabecular meshwork again. And that there you can see the palisates. Moving back to my presentation, ma'am. Now about our future plans. Our future plans are to actually assess the effectiveness of virtual reality aided teaching over traditional methods. And then it is to make virtual reality based models for various pathological conditions of the eye, such as retinal detachment, corneal ulcer, diabetic retinopathy, cataract, etc. And then it is to develop virtual reality assisted surgical training. Now, I extend my sincere gratitude to the mind behind this whole project, our HOD, Dr. Gopal S. Pillai, and Dr. Mahesh K. And I also extend my sincere gratitude to Dr. Yashovardhan Singh Sivaj for taking his time and guiding me throughout this project. And a big hand to our technicians, Mr. Sarin Xavier and Mr. Suji Chandru, without whom this project would not have been a reality. Once again, I thank you all.
Thank you, Niveda, sorry.
Yes, ma'am.
It was a very nice presentation and a very good invention, and definitely will be a boon for the benefit for the students as well as for the teachers, also for training purposes of the students. Future plans are wonderful. And I have just one question. Will it be easily available for all the students, or it will be costing exuberantly that it will be difficult to buy these?
Ma'am, yes, ma'am. Actually, it is not actually very costly because we've developed it using the software called Unity, which is a gaming app. So if you have a nice computer with this app, you can very well see the eye. So we can share the software, just like any video game CD, you will be able to see it. So it is economical also, ma'am. As you know, not all colleges have medical illustrations and medical simulation centers like our campus do. That's why we've made it in a CD format.
Okay, I don't think so. I have any questions. A very good step, and I hope everybody will be benefited by it. And I pray that you people come out with new inventions soon, so that earlier the better for the students. Thank you so much.
Thank you, ma'am. Thank you, ma'am.
Okay, who is the next speaker? Sunil Nagaraj?
Ma'am, I'm the support person.
Oh, sorry. Is there any more students left? Is there any more presenter over there? I think so. Everybody has presented. There were 3 candidates. And I just wanted to ask Dr. Samantha, is he there? Hello?
Nobody there, ma'am. There's nobody there as of now.
Okay, so we can wind up now. I'll submit the marks to Dr. Samantha directly on